earlier you did touch on hysteroscopic resection of fibroids. Excuse my pronunciation of that one. Could you please explain that and how it addresses uterine fibroids?
Yes. So when there are two surgical procedures used in fibroids. If you remove fibroid from outside the uterus, it's called myomectomy. Even if you remove the fibroid from inside the uterus, it's called resection. So I know it's used interchangeably. Generally, it is when it says myomectomy, it means that you have a keyhole surgery or open surgery, and you make the cut from surface of the uterus, from outside the uterus, or serosa of the uterus. If you remove the fibroid, mucosal fibroid, from inside the uterus, that's called resection of the fibroid. So for that, you use a hysteroscopy. So that's called hysteroscopic resection of fibroid for submucosal fibroids. So, or if you say myomectomy, you normally say open myomectomy or laparoscopic myomectomy. Hysteroscopic resection of myomectomies, like we said, indicate on type 0 and type 1 submucosal fibroids. It's not indicated on type 2 or type 3 submucosal fibroids. Type 3 means you can have a fibroid that's just touching endometrial lining, but not going into the cavity. Type 2 means less than 50% is going into the cavity. So those fibroids should not be managed with hysteroscopy. Why? Because, like we said, it can cause Asherman syndrome. We really don't like Asherman syndrome in IVF setting, because this is one condition. It can significantly negatively impact implantation. It causes very thin endometrium. It causes a lot of scar tissue in endometrium, a lot of fluid collection in endometrium. It's very difficult to manage. So this is why we need to do everything. When patients have any surgery inside the uterus, we need to minimize risk of Asherman syndrome. So hysteroscopic myomectomy is generally very safe procedure. Generally lasts 30 minutes, 40 minutes. In general, patients have anesthetic, then they have a hysteroscopy. No cuts, no keyhole surgery, no open surgery. Hysteroscopy. You put the camera from inside the cervix, go into the uterine cavity, and then you can see whole cavity, like you are seeing whole big room. Then you can detect where the fibroid is growing. Then you use electrode, bipolar electrode, which is hot wire, and start cutting that fibroid and remove the fibroid. So, and that's very effective, very generally safe procedure for type 0 and type 1 fibroids. Importantly, after hysteroscopic resection, so you need to ensure that you don't have a adhesion formation or Asherman syndrome formation. You can do it by second look hysteroscopy, which means next month you look again to make sure that on the place of a raw area of the surface, you don't have a scar tissue formation. So, and then, or if you can't do repeat hysteroscopy, you need to monitor by doing ultrasound scan, making sure that in the next month endometrium growing fine, it's more than 7 millimeters, there's no scar tissue, no fluid collection, to ensure that Asherman syndrome is not developing. If it is developing, you need to do another hysteroscopy to remove scar tissue, disrupt the scar before the scar becomes very established. So, and yes, otherwise hysteroscopic myomectomies are very simple and very straightforward and effective.